Hi, welcome back to Group Crisis Intervention. In Section 2, we're going to talk about the psychological and behavioral reactions to stressors. This should help us better understand how to apply the group intervention techniques we're going to learn in this class. The information to help you with this section is found in this slide presentation and also in pages 35 to 45 of the course booklet. The signs and symptoms of distress and dysfunction can be broken down into 5 general categories, and it's helpful that we understand this when we are providing interventions to individuals and observing them for signs and symptoms of significant distress. We have cognitive, affecting thinking, reasoning, and problem solving; emotional; behavioral, not only just actions which we may seem are drastic, but also changes in normal working or daily behaviors; physical signs and symptoms indicating the possibility of injury or illness; and spiritual, those kinds of statements or symptoms which may indicate that the person is having a problem with his or her faith. A quick clarification on a couple of terms: stressor and the stress response, because there's a difference. The stressor is the cause. It's the stimulus in the stimulus response continuum. So it initiates a stress response in the person. Stress is arousal in response to a stimulus. It's not specific, which means that it can attack multiple parts of the body depending on its intensity and the nature of the stressor and the nature of the individual who is being stressed. It's important we understand the difference because in CISM we focus on the response. We focus on how the individual is responding or reacting to the event. The stressor is the event or critical incident. That's not what we're there to focus on. So stress is one of those terms that people often use but may or may not understand the complexity of what stress is. It involves neurological, neuroendocrine, and endocrine arousal response mechanisms. It can affect every organ, every function in the body, from mental and brain function, reasoning, emotional responses, and it can also accelerate the aging process over time. So a basic understanding of general adaptation syndrome will help us understand how the individual or individuals we're helping got to where he or she is in response to the critical incident. So initially you have an alarm, a stimulus that causes some kind of arousal of your body's defense mechanisms and coping mechanisms. Your body then uses resistance to help to cope with this arousal. So you have behaviors or strategies that you attempt to use to cope with what has happened. But eventually those systems become exhausted, and now we get to a period where the individual is no longer able to sum up the energy to resist the effects of a potential stressor. And this is where we see individuals in critical incident stress response. So here's a graphic representation to help try to understand what the body is doing and what the individual is doing after exposure to a traumatic event. We're going to have the point of time at which the stimulus takes place. And the body's going to have its alarm responses, psychological, physical, emotional, etc. And so now you're in a heightened state, and your body uses its mechanisms, your brain uses its mechanisms in an attempt to cope with this terrible event. And eventually fatigue takes place if the stimulus is more than your coping mechanisms can handle. And when that happens, your physical and emotional state goes into a state of exhaustion. And you may actually become worse and are likely to potentially become quote unquote worse than you were before the event took place. Emotionally drained, maybe you're losing your ability to make decisions, etc. After this takes place, the goal of crisis intervention is to help you recover back to some semblance of where you were at the baseline. So we mentioned earlier that there's different kinds of stress, and we have eustress or positive or pleasant or things that don't create a negative, potentially harmful situation, and a list of those is presented here in the slide. And then we also have what we call the negative stressors or the harmful stressors, what we call distress. Some of those are individual in nature. Some of those are relatively small in the amount of people they impact. For example, something that might happen at work, something that might occur within your family. But then we also have the large scale things like natural disasters, terrorism, things like that. So when we look at the stress situation, when you have positive stressors, your health, your performance, your mental and emotional state may improve up until you get to the point that you're maxed out. Then, either because of exposure to a negative stressor, a terrible event, or when the amount of stress becomes excessive and you can no longer deal with it, then we start to see decreases in your health and performance. So this point at the arrow kind of represents the most you can take. Now, if it's a positive stressor, hopefully it levels out. But when the situation becomes negative stress, we start to see the decline in your health and performance. This is something for which coping mechanisms and some level of recovery needs to take place. So if we have to make a generalization, we can say that stress in itself is usually not dangerous until it becomes prolonged, intense, is intensely negative, or is more than the individual can tolerate. We hear the term burnout used frequently when we talk about individuals who can't take the stress of their job or life anymore, or are at a point where, as they might put it, I just can't do this anymore. The more appropriate term for the stimulus is probably cumulative stress, and the individual will exhibit signs and symptoms from their reaction or response to cumulative stress. It's unmitigated stress that takes place and builds up over time, and there are three identifiable phases. The arousal, or the initial responses, energy conservation, which is the person attempting to adjust behaviors and thought patterns to cope with this ongoing stress, and finally exhaustion, which is the point at which we see the critical incident stress signs and symptoms overcoming the person's coping mechanisms. So let's start with physiological responses to stress. There are certain areas in the body and certain sections of the mind which are kind of targets of stress. They're the areas where we see the body have breakdowns or have signs and symptoms as a result of someone's exposure to stress. Why do we need to know this? Because if someone is having something that presents as a potential physical problem or a medical emergency, this person needs to obviously get to medical care quickly. When we're doing crisis intervention, we're working with the psychological impact from the event. If someone is showing physiological signs which are concerning, then that person should be referred immediately. Kind of works like this. We have a stressor take place. We get a stress response, and that stress response happens to take place in the target organs of the body. So, here's an example. You get caught in a traffic jam. Your body secretes adrenaline. You're aggravated. You don't like it. It's a typical response. Your heart rate increases, your blood pressure goes up, and other things take place as a result of this increase in adrenaline production. We can call them anxiety. Sometimes it gets to the point of anger. But what we're seeing is a stressor took place that caused a response, in this case, which was physiological, and we have observed physiological signs and symptoms of that response. So how does this all relate to why you're in this course? We know that trauma is a horrific event. It's outside of usual experience, but as medical practitioners, we tend to see that horrific events that occur to our patients, or people we often refer to as our athletes, are outside of the realm of the normal human experience, but they may not be something that we would consider to be outside of the expectations of things to which the athletic trainer was going to be exposed. That doesn't mean that you're not going to find it to be particularly distressing or that it's not going to be upsetting to you. If you have an athlete who's near death or someone who dies under your care or in your program, this can be pretty distressing. So in this course, we're not focused on him. We're focused on them after this is over. How did they react to it? How are they responding? How are they coping? So traumatic stress is the most intense form of distress. It's acute, it's often intense, it's often upsetting, okay? It's the kind of reaction that takes place after the traumatic event is over. It's sudden. And they vary considerably, and a lot of that is related to the background and the training and the personality of the individual who has suffered the traumatic experience. Sometimes it's minor and sometimes it's very debilitating. We see a wide range of cognitive and physical and emotional and spiritual and behavioral responses and reactions that take place after someone has been exposed to some kind of traumatic event. One thing to take away from this point is that it's not whether or not the event is traumatic to you or upsetting to you. It's a traumatic event if it's upsetting or causing disruptions to the individual for whom you are providing the intervention, or to individuals in the group for whom you are providing the intervention. So like we said, post-traumatic stress is intense. It happens as a reaction to the event. It almost always occurs after a sudden and unexpected event. And the reactions can vary considerably. You could be minor disruption, you could maybe cry for a few minutes, and then your coping mechanisms kick in to the point where the reactions are severe, debilitating, and could potentially negatively affect their health. Keep in your mind, and don't be afraid to communicate, that critical incident stress and the responses that the person or group is seeing to the critical incident are normal. People who go through traumatic experiences may well exhibit a certain set of behavioral, cognitive, and emotional changes. We want to make sure that the people with whom we work understand that what they're going through is normal for people who've been through what you've been through. It doesn't mean that you are abnormal or have an issue. But let's throw up the red flag about PTSD. Not everyone who goes through a traumatic event and suffers critical incident stress develops PTSD. They may show some signs or symptoms initially that are similar to those, but we want to be aware that PTSD is a persistent mental and emotional condition. The ICD-10 defines PTSD as having the symptoms and the various reactions from the traumatic event or events lasting more than 30 days. Many times, individuals who are exposed to traumatic events and who might have critical incident stress don't need mental health intervention or psychological counseling. Many times they simply need a critical incident intervention, a crisis intervention. And part of the crisis intervention helps identify the need for additional care. So we don't want to throw around the term PTSD willy-nilly, because it's a specific disorder that has had to have been in place for an amount of time. Okay, here comes the but. We said that not everyone who is exposed to a traumatic event and has critical incident stress suffers from PTSD. But if that stress is not managed properly, if it remains unresolved, you can get one or more psychological conditions interfering with normal life. And there are a multitude of those which would need to be diagnosed and managed by a mental health professional. One of the worst of those conditions is PTSD. So to help you understand the difference between PTSD as a phenomenon and helping someone with their critical incident stress response, let's look at what are the criteria for diagnosis with PTSD. There has to be exposure to an actual threat, sexual violence, serious injury, etc. There have to be symptoms of intrusion associated with the event. There has to be avoidance of stimuli that are associated with the event. In other words, things that you're exposed to later on can cause or exacerbate symptoms. There are negative changes in your mood and thinking. We have marked alterations in your arousal and reactivity. And the duration of those things is at least 30 days. So PTSD is an ongoing problem. There's significant distress and or impairment in one or more areas. And it's not attributable to drugs, alcohol, or some other kind of chemical influence. As we learn about crisis intervention and we begin to get involved with crisis intervention techniques, we want to make sure we don't have blinders on. There are other conditions that we can see in individuals which may occur as frequently or more commonly than PTSD. We can see people turning to substance abuse, withdrawal behaviors, developing depression, psychosis, panic attacks and panic disorder, personality changes, things that affect people's confidence and their level of anxiety and irritability. When these kinds of conditions present, it's probably a very good idea to refer individuals out for mental health care with a mental health professional. So after people have been exposed to traumatic events or bad things, they tend to form a membrane around themselves to try to insulate themselves from additional trauma and from additional negative experiences. And this is called a trauma membrane. And over time, it can be something that can appropriately block out or reduce the effect of traumatic stimuli on that individual. But one way to make sure that the traumatic membrane is appropriate is to intervene early when individuals are exposed to traumatic events. And when you look at the schedule of how things should happen in the ideal world with CISM, you can see that early intervention is one of the things that is highly recommended. So finally, I want to remind you of the general types of signs and symptoms of traumatic stress. We have cognitive, emotional, behavioral, physical, and spiritual. So we're kind of done with section 2, so this is probably a good time to take a break, and section 3 will be next.